Excuse me. Alright guys, now that you had a chance to take a break, we're going to pick up with labor and delivery. Now towards the end of a full-term pregnancy, or during the third trimester, the fetus normally moves into a head-down position. Once the head descends through the broad upper inlet of the mother's pelvis, the uterus moves downward and forward. This is how the process of delivery. Now this process also consists of contractions of the uterus, and what this doing is helps expelling the fetus as well as placenta out of the uterus. Now delivery is divided within 3 stages. You have dilation, expulsion, as well as placental delivery. Now the length of each stage varies based off the patient as well as various circumstances. Now during the first stage, the uterine is contracting and causing dilation of the cervix, opening it up so that way the baby can come through. During the second stage is when you have the birth or expulsion of the baby, and ideally it should be the head coming out first. And then the third stage is delivery of the placenta. The first stage of delivery is from the beginning of true labor or contractions to complete cervical dilation and 100% effacement. During this first and longest stage, the cervix becomes fully dilated at 10 centimeters. The patient may also have Braxton Hicks contractions becoming more frequent during pregnancy. The patient will feel like they're having contractions, but it is not true labor. For us in the field, we cannot differentiate between Braxton Hicks contractions and true labor within the pre-hospital setting. So any patients who's having contractions, we want to transport quickly to the hospital. With the onset of true labor, contractions become more frequent, they begin lasting longer, and they become more intense. This pattern continues until contractions occur less than 2 minutes apart, last longer than 60 seconds, and are 10 plus on the pain scale. Once the first stage is completed, the mother then enters the second stage, and this is when the infant is moving through the vagina and is born. Contractions, as we just said, are less than 2 minutes apart and last about 60 to 90 seconds. As the infant moves down the birth canal, the mother may feel like she has to go to the bathroom because the infant is placing pressure onto her rectum. The mother, because this tightening and bearing down sensation becoming stronger and more frequent, they have an uncontrollable urge to push downwards to help push the baby out. During the second stage, the perineum will also begin to bulge, the perineum being that space between the vagina and the rectum. The infant will begin to crown, so you'll actually be able to look and you'll be able to see the top of the head. When the head is the presenting part within the vaginal opening, this is referred to as a vertex presentation. At this point, the mother should be coached to push with each contraction. The shoulders and the rest of the baby's body will follow after the head is delivered. For the patient for whom this is the first delivery, the second stage typically lasts between 50 to 60 minutes. The third stage is when the placenta is being delivered. This usually occurs within 5 to 20 minutes post-birth. We do not pull on the umbilical cord to help facilitate delivery of the placenta, because it can potentially cause the uterus to invert. If it becomes inverted, the uterus cannot contract and tone up effectively. The exposed uterine vessels continue to bleed and lead to serious hemorrhaging and hypovolemia of the patient. Signs that delivery of the placenta is imminent is a sudden increase in bleeding from the vagina, the uterus becomes smaller in size, The umbilical cord begins to lengthen, and the mother has an urge to push again. When assessing these patients, first thing we want to do is determine whether or not delivery is imminent. If the delivery is not imminent, it's best to transport the mother so that way delivery can occur in a controlled environment such as at the hospital. To determine whether you should transport or commit to an on-scene delivery, answer the following questions. What's the age of the pregnant patient? How many times have they been pregnant? Because the more times a patient is pregnant, the quicker the delivery. How long have they been pregnant, and what's the estimated due date? Has the amniotic sac ruptured? If so, when and what color was the fluid? Has there been any fetal movement? Any contractions, frequency and duration of the contractions? You want to look and see if there's any crowning. Do they do they feel the need to push or have a bowel movement? Is the abdomen or uterus hard upon palpation? And have they been taking any medications? You also want to estimate gestational age based on fundal height. The closer the top of the fundus or the top of the uterus is to the xiphoid process, the higher the number of weeks of gestation. If the fundus is located at the umbilicus or the belly button, you're at 20 weeks. And once we get to once it reaches the xiphoid process, we're at 38 weeks. At 40 weeks, the fundus drops to below the xiphoid as the fetus moves into position for delivery. For a pre-hospital delivery, there has to be no suitable transportation for the mother. Delivery is imminent, or there may be severe weather, natural disaster, or catastrophe that makes it where you cannot reach a hospital or physician. If any of these situations are present, you must assist in delivery of the baby. If birth is imminent with crowning, the top of the head is the presenting part, and the patient is pushing with contractions. Once this happens, it's time to commit. You're about to deliver this baby. The patient's abdomen extremely hard. If it is imminent, you want to take standard precautions. If you are to assist the mother in delivery, stay calm. That's the last thing they need is for you to start freaking out. Explain to them that you are trained to help. Ensure their comfort, their modesty, and peace of mind as much as possible, and try to limit distractions and onlookers. Do not touch anywhere around the vaginal area except during delivery. Don't allow the patient to use the toilet because she may accidentally deliver that fetus into the toilet. Don't hold their legs together and use a sterile OB kit that should be on your truck. Take all standard precautions as needed. Give your patient oxygen via nasal cannula. You want to position your patient by having them lay supine on a firm surface with their knees drawn up to their chest as far as possible and legs spread apart. This is referred to as the McRoberts position. By placing the patient in this position, the distance between the symphysis pubis and sacrum increase slightly, which might make it easier for the fetus to pass through the opening of the pelvis during delivery. Use sheets from your OB kit, sterile towels, or paper barriers to help create that sterile field. Remove the patient's clothing or push it up above their waist. Place one sheet under their hips, unfolding it towards their feet, and another sheet over their abdomen and legs. Have your partner or a close family member stay at the patient's head in case they have to vomit. And as the head appears or crowning, have the patient push hard with each contraction. The normal head presentation is occiput anterior, where the back of the head is facing upward and the face of the baby is downward. Within your OB kit, you'll have everything that you'll need. You'll have your suction bulb, sterile sheets, sterile dressings, padding, clamps, everything that you'll need to help deliver that baby. You want to make sure that you have your OB kit or equipment within reach, but away from the birth canal so that it won't be contaminated by vaginal discharge, blood, and amniotic fluid. As the delivery is progressing, you want to exert very gentle pressure on the top of the head to prevent an explosive delivery. Avoid touching and exerting any pressure on the baby's face or on any soft spot or the fontanelles on the head. The amniotic sac will appear as a membrane with fluid between it and the baby's head. If it is not ruptured, this is when you want to tear it. All you're going to use is your fingers to rupture the sac and tear it away from the head and face as it appears. You then want to determine the possibility of a nuchal cord where the umbilical cord has become wrapped around the neck. If this occurs, the nuchal cord must be managed immediately once it's found. Use 2 fingers to slip the cord over the shoulders or head, and if you cannot move the cord, place 2 clamps 2 to 3 inches apart and cut between the clamps using scissors. Excuse me. Suction the nose and mouth of the newborn immediately following birth, only when secretions or other substances are present that could obstruct spontaneous breathing. With both hands supporting the head of the baby, apply slight downward movement that enables the upper shoulder to deliver. With both hands continuing to support the head, apply slight upward movement that enables the upper shoulder to deliver. Slight upward movement that enables the lower shoulder to deliver. Typically, after the shoulders have become delivered, the remainder of the body follows pretty rapidly. Never pull the baby from the vagina or apply traction. Do not put your fingers in the baby's armpit. Pressure there can cause damage to the nerve centers, resulting in permanent damage. Receive the newborn in a clean or sterile towel to help you hold it securely, and be sure to support the head and neck as the baby does not have the ability to hold them up yet. That will come later in life. Once the baby has been delivered, do not pull on the umbilical cord as you lift or receive the newborn. Keep the baby at the level of the uterus. Don't lift the baby high above or low below the mother's uterus. Immediately dry the baby with towels. Remove any wet towels well away from the infant's body to avoid inadvertent cooling. Place him in a warm, dry blanket. Wrap with plastic wrap or place in a food-grade Ziploc storage bag with the head exposed and on its back with the head in a sniffing position to maintain an open airway. It is recommended that a delay of at least 30 seconds should occur before actually cutting the cord. It's been found that delayed cord clamping results in the following for the newborn, such as less cerebral hemorrhaging, higher blood pressure, increased blood volume, less of a need for transfusion after birth, and less chance of necrotizing enterocolitis. Your APGAR score should occur between 1 minute and should be done at 1 minute and 5 minutes after birth. And what this does, it provides a numerical means to determine the need and or effectiveness of newborn care and the need for further resuscitation. After you've waited about 30 seconds, you want to clamp the umbilical cord, wait for it to stop pulsating, and you'll cut in between. You want to try to keep them warm. Do everything you can to prevent newborn hypothermia. You're probably going to want to turn on the heat in the back of the truck to keep it as warm as possible. If you have one, you want to apply a neonatal pulse ox. Monitor the respirations, heart rate, and O2 sat. Assess for delivery of the placenta. It's usually delivered within 10 minutes of the baby's delivery and almost always within 20 minutes. Once it's been delivered, place it in a plastic bag contained within the OB kit and transport it to the hospital with the mother. After the placenta has been delivered, you want to place a sanitary pad or sterile dressing over the vaginal opening as well as the perineum. There will be vaginal bleeding after delivery. Upwards to 500 milliliters of blood loss is considered normal, and the mother can usually tolerate it pretty well. If the mother's blood loss appears to be excessive, provide care as you normally would for postpartum hemorrhaging. Immediately begin uterine massage by massaging the fundus. And what you're doing by massaging the uterus after delivery, it helps to stimulate smooth muscle contractions, which decreases uterine size and tone of the smooth muscles of the uterus, causing it to contract around the exposed bleeding vessels where the placenta sheared off and tamponade off the bleeding. You can also allow the newborn to start breastfeeding, and this releases oxytocin, which can also help cause the uterus to contract. Record the time of delivery, transport the mother as well as the newborn and placenta to the hospital, and then reassess as needed. So as the crowning and the vertex of the head is showing within the vaginal canal, you can apply easy pressure to avoid an explosive delivery. You can even apply slight pressure to the perineum to help keep it from rupturing as well. Once the head is delivered, you want to look to see if the umbilical cord has become wrapped around the neck. If not, then continue with birth, supporting the head. Do not apply traction, and deliver the shoulders with the next contraction. After the shoulders have come through, the torso and the rest of the body will become expelled. You want to support them with both hands. Make sure you have a firm grip, but not too tight on the infant. Make sure you keep a good grasp. Keep them level with the mother's body. Immediately dry the newborn with towels. Keep them dry. Place them in a warm, dry blanket. Wrap them with plastic wrap because that will help with insulation. And then you want to clamp and cut the umbilical cord. Once the placenta appears to the vagina, grasp it gently. Never pull or tug on the umbilical cord. Instead, slowly and gently guide the placenta and the attached membranes from the vagina. If needed, you may need to provide blow-by oxygen based on your SpO2 reading. Go through for an abnormal delivery, labor and delivery at less than with less than 37 weeks of gestation and reoccurrence of contractions after the first baby is born are also signs of an abnormal delivery. You want to go through your assessment of the patient. Is there any presentation besides normal crowning? Their umbilical cord protruding from the vagina, or amniotic fluid with an abnormal color or smell. Amniotic fluid should be, for the most part, a clearish color. Maybe it might be slightly yellow tinged. Y'all give me just a second. Oh, sorry about that, guys. Where was I? Oh yeah. Normally, like I said, amniotic fluid is like a clear, maybe slight yellowish tinge. But if it comes out a greenish brown color, and it's a very putrid smell, that would be present for meconium fluid and a sign of fetal distress. Emphasis for any abnormal delivery is immediate transport of the patient, giving them oxygen, monitoring vitals. For most intrapartum emergencies, delivery in the pre-hospital setting is not possible. So you'll not need to contact medical control for further orders, and in some emergencies, medical direction might recommend that you perform certain maneuvers to facilitate the delivery of the baby. Alright, that being said, one of these intrapartum emergencies is called a prolapsed cord. This is when the umbilical cord is the actual presenting part. Instead of the head, the cord presents first. What happens is as the baby continues to come down, the cord becomes more compressed, thus cutting off oxygen to the infant. So you want to instruct the mother not to push. So what you're going to do is you're going to insert a gloved hand into the vagina. So one of the rare times that we will do this. and gently push or lift the presenting part of the fetus, head, or buttocks up, back, or away from the pulsating cord. Do not try to push the cord back into the vagina. An intrapartum emergency is one that occurs during the period from the onset of labor to the actual delivery of the newborn. Several conditions could potentially lead to an abnormal delivery. In almost all of these conditions, delivery at the scene or en route is not possible, and immediate expeditious emergency transport to a medical facility that can manage obstetric emergencies is necessary. You want to place these patients in a knee to chest position. So there's your cord coming out first. Apply the mother on oxygen. Insert your hand to help get pressure back off that placenta. If any of the cord is portion of the cord that is out, you'll also going to want to wrap it in a sterile moist towel to prevent it from becoming drying out and clotting. Breech birth is when either the buttocks or the lower extremities are the presenting portion. This condition also presents a high risk of fetal complications due to the chance of the baby becoming hung up. In the event of a breech delivery with only legs and buttocks visible within the vaginal opening during crowning, instruct the patient not to push. Instead, have them pant during their contractions. Administer high concentration oxygen at 15 liters via an under-breather. Place a hand in the vagina on the presenting part to keep the fetus from being delivered. Transport the patient immediately to the nearest hospital with OB services in a supine head-down position to help use gravity to your advantage to keep that baby in. Contact medical direction for further orders, and if transport will not be delayed, consider ALS backup to deliver medications to stop uterine contraction and delivery. In the event that you do have to deliver, a frank breech is where the hips are flexed and the knees are extended. This makes up about approximately 60 to 65% of all breech presentations. Because of the position of the buttocks and legs, it creates a fairly good dilating wedge. Therefore, umbilical cord prolapse is less likely to occur. A complete breech is where the hips and knees are flexed. It is less common and occurs in approximately 5% of all breech presentations. If an incomplete breech, the hips are flexed and either one or both feet are the presenting part. Incomplete breech occurs in 25 to 35% of all breech presentations. This presentation provides the porous dilating wedge and provides the less filling of the pelvic and cervical opening. If it is unavoidable, contact medical control for assistance. Have the mother push hard during contractions. The rest of the deliveries, as you would normally, support the legs. Allow the legs and buttocks to deliver until the umbilicus is seen. If the head is able to be delivered, great. However, there is a high chance of it becoming entrapped. If the head still cannot be delivered, contact medical control for further orders. Medical direction may instruct you to perform the Vaginal maneuver. This maneuver would require you to attempt to replace the born fetal parts into the uterus. The patient would then be transported to a medical facility capable of performing OB care so that an emergency cesarean birth could be performed. Follow your medical direction and local protocol. If the buttocks are delivering first or a frank breech, medical control might instruct you to perform the Mariceau Maneuver. With the Mariceau Maneuver, one EMT would apply suprapubic pressure as the other EMT places their dominant hand on the fetal shoulders. The second EMT places their dominant hand inside the vagina and places two fingers on the maxilla, or the bony part of the face just below the nose, and applies downward pressure on the maxilla, causing the fetal head to flex forward. The forearm is then supporting the weight of the baby's body that has already been delivered. The baby's body is is elevated gently toward the mother's abdomen while keeping the head flexed. Suprapubic pressure is maintained during the entire procedure. Uh, what you're doing in the event that you're not able to at least get the baby out, but you're at least making a spot in there so that way the baby can breathe. Face, chin, brow, limb, and compound presentations is literally what the names imply. When crowning, a face presentation is when the face is the presenting part, a chin is when the chin is the presenting part, and a brow is when the eyebrows or an eyebrow are the presenting part in the vaginal opening. If an arm or leg is the presenting part, vaginal delivery is impossible, so you want to apply oxygen and transport the patient in the knee-chest position. This is considered a limb presentation. When an arm or leg enters the birth canal and presents with the head or buttocks, it is termed a compound presentation. Do not do anything else. Do not try to push it back in. You need to emergency transport this patient to the hospital so that before they can handle OB patients. Shoulder dystocia, this is when the fetal shoulders are larger than the fetal head. This usually occurs when the mother carries the baby longer than she should. Complications associated with dystocia to the fetus could be asphyxia, injury to the brachial plexus, to the mother, trauma to the uterus, vagina, and perineum. What's happening is as the head delivers, the shoulders are getting caught on the pubic symphysis and it is drawing the head back in. This is often referred to as the turtle sign because it's going turtle, turtle, in and out. This continues to occur with each contraction following delivery of the head when the shoulders cannot be delivered. Emergency care for these patients is to place them in the McRoberts position. If the McRoberts position alone does not work, you could try applying suprapubic pressure. And if both of these do not allow the delivery of the shoulders, you may be instructed by medical direction to attempt the Gaskin maneuver. If none of these procedures work, you must begin emergency transport immediately, and the mother must now be instructed not to push with each contraction, and contact medical control for further orders while en route. Precipitous delivery, this is when a baby is being delivered within 3 hours of onset of labor. The delivery would be conducted in the same manner as any other delivery. However, it may occur rapidly and without much warning. Other than that, the care for the neonate is the same as in normal delivery. However, there is an increased risk of trauma to both the baby and mother because neither one of them was fully prepared for delivery. The cervix may not be fully dilated yet. The placenta may not be ready to deliver. There's so much that has to go on up until the point of delivery after the onset of labor. Be prepared for multiple births as well. If after the delivery the abdomen is still very large after one infant has been delivered. Their contractions continue to be strong, or even the infant being smaller than when compared to the abdomen. If you do suspect there's more than one baby, you do want to call for assistance because now you're about to be handling more patients than what you can handle. Approximately a third of all deliveries of the second baby will be breech, so assess carefully and take immediate action. If the second baby is not breech, you want to just handle the delivery as you would for a single baby. Meconium, this is that fetal distress. This is most often seen in breech births. Typically, the thicker and darker the color of the meconium, the higher the risk for fetal problems. There is a chance for the baby to aspirate on it, which can result in pneumonia. If meconium is present but the newborn has a good cry or vigorous activity, do not attempt suctioning. If the baby is depressed or non-vigorous and their pulse is less than 100, you want to quickly suction and begin positive pressure ventilation. When the fetus becomes hypoxic, the digestive tract increases movement and the anal sphincter relaxes, causing meconium to be released into the amniotic fluid. In a breech delivery, the uterus contracts against the fetus head and stimulates the parasympathetic nervous system, which increases the peristalsis within the intestines, making meconium staining more likely to occur. Yes, ladies and gentlemen, meconium is the infant's feces. Preterm labor. This is labor that occurs between weeks 20 and 37. A mother with a history of preterm labor is usually placed on bed rest during pregnancy. Preterm labor does carry a higher incidence of abnormal presentations of the fetus during delivery. One of the more common causes known to induce labor is cocaine and other vasoconstrictive medications or drugs. Care for these patients is not to allow the mother to push, keep her on oxygen, and transport to the hospital. If we can get her there in time, they could potentially give her medication to stop the labor process and monitor her throughout the course of her pregnancy. Preterm birth. This is any infant weighing less than 5 pounds or born before week 37 gestation. These babies are much thinner and smaller. Its skin has a reddened and wrinkled appearance. They're due to their skin being thin, they're more prone to hypothermia. Their respiratory system and surfactant hasn't fully developed, so they're also at a greater risk for respiratory issues. Care for the premature baby. You want to keep them dry, keep them warm, suction as needed, administer oxygen, try to keep them from becoming contaminated. Also, don't let anyone breathe into their face because they're also highly susceptible to infection. And just monitor them and get them to the hospital quickly, where they can be placed into an isolate. Post-term delivery. This is delivery beyond 42 weeks of delivery. Post-mature baby are more prone to insufficient oxygen and nutrient delivery, hypoxia, hardened skull that causes a more difficult delivery, and the presence of meconium from increased bowel maturity. The post-mature fetus is at greater risk also for intrapartum hypoxia because of the inability of the placenta to meet the demands of the fetus during labor. Premature rupture of membranes, or PROM, is a spontaneous rupture of the amniotic sac prior to onset of true labor. Infection of the amniotic fluid or dry delivery places stress on the fetus during labor and delivery. These babies often need additional resuscitation beyond normal newborn care after being delivered. What happens is the membranes rupture, amniotic fluid empties out, baby's still in there. What that fluid is meant for, as once it ruptures, it's meant to lubricate the vaginal canal at the time of birth. It is possible, though, with surgical interventions, that they could possibly reseal what ruptured and possibly refill the amniotic sac with artificial or synthetic amniotic fluid. Postpartum hemorrhaging. This is most common in multi-gravida patients following multiple births or delivery of a large baby. Prolonged labor and precipitous delivery can lead to failure of the uterus to tone as well. To treat postpartum hemorrhaging, you want to provide the patient with a fundal massage, where you're actually massaging the uterus or the top of the fundus. Administer oxygen and transport the patient. Another postpartum complication that you may come across is an embolism. What happens is you have clots forming within the venous system. These clots break off, go into the lungs, causes the pulmonary embolism or PE. The patient with a PE can present with shortness of breath, syncope, tachycardia, sharp chest pain, hypotension, cyanosis, as well as pale, cool, clammy skin. For these patients, you want to provide oxygen via non-rebreather at 15 liters and transport the patient quickly to the hospital. When taking care of a newborn patient, you want to keep in mind these neonates, these newborn infants, they don't have a weight, they're unable to thermoregulate. So they're going to lose their body heat very quick. So we want to make sure that we keep them nice and warm. Suction only if obstruction to the breathing is present, otherwise let them breathe on their own. Go through and assess your APGAR at the 1 minute and 5 minutes. The lowest score that they can get is 0. The highest they can get is a 10. We monitor based off their appearance, pulse, grimace, activity, and respirations. For appearance, they earn 0 points if the entire body is pale or blue, 1 point if the body's pink but the extremities are blue, and 2 points if the entire body and extremities are pink. For pulse, no pulse is 0, 1 point for a heart rate less than 100, 2 points for a heart rate greater than 100. Grimace or reflex irritability, 0 points for no reflex, 1 point for some facial grimace, and 2 points for a grimace with a cough, sneeze, or crying. Activity, if they are limp or no movement, they get 0. If there is some flexion of the neonate, they get 1 point. And if they're moving all of their extremities, it is 2 points. For respiration, if they are not breathing, it's a 0. 1 point for slow or irregular breathing effort or a weak cry, and 2 points for good respiration and a strong cry. We use the APGAR to determine the need for resuscitation. Anything less than 7 is when we want to provide, is when we're going to start providing more intensive care. 0 to 3 is when we want to consider positive pressure ventilation, CPR, and it's between 7 and 10 we're just going to provide routine care and just monitor. En route to the hospital, you want to provide continual assessment for the newborn, paying particular attention to body temperature, airway, breathing, oxygenation status, heart rate, color, and activity level. Contact medical control to update them on any conditional changes of the mother as well as the newborn. If they're not breathing adequately, we can try simple stimulation, such as rubbing their back or even flicking the soles of their feet. Most newborns, if you ever do deliver in the field, they will not require any resuscitation besides just monitoring their temperature and a little stimulation of suctioning. Go through and assess your patient. Signs of severe depressed newborn include a respiratory rate over 60, diminished breath sounds, heart rate over 180, 180, or under 100 per minute. Signs of trauma, poor skeletal muscle tone, poor peripheral perfusion, cyanosis, APGAR score less than 4, also a heavy meconial staining or amniotic fluid, and a non-vigorous newborn. The establishment and maintenance of an adequate airway, ventilation, and oxygenation is the cornerstone treatment for any newborn who does not exhibit vigorous activity following birth. Their O2 readings, if you're able to obtain them, are based on preductal readings, which are obtained from the right upper extremity. Now, to reach normal levels is going to take several minutes. Such as if you go and assess at 3 minutes, we're only going to be expecting it at 70 to 75%. Because they're having to get, now they are breathing on their own. So they've got to get blood or oxygen circulating into their own blood. It's going to take, it doesn't happen immediately. So it may take up to 10 minutes just for them to get up to that 90% threshold. Approximately 80% of newborns, as I said, require no resuscitation beyond keeping them warm and keeping their airway clear of secretions. To provide blow-by oxygen, you just hold the tube 1 inch from the baby's nose and mouth and direct oxygen flow about 15 liters per minute or greater across the mouth and nose, making sure that the baby is kept warm and also the airway remains clear. Always start with least invasive, such as if they're not breathing, we want to try tactile stimulation, such as flicking their foot or rubbing their back. Only a small number will ever require chest compressions, and even smaller number will require the use of medications or even an advanced airway that an ALS team could provide. If the answer to all of these three questions are yes, the newborn should not require any resuscitation beyond normal newborn care and be kept with the mother for transportation, provided the mother is not experiencing any life-threatening complications. If you've answered no to any of these three questions, the newborn will require one or more additional interventions. The newborn resuscitation steps follow. In many of these interventions, after 60 seconds, reassess to determine the need for continued intervention. The entire time this newborn is in your care, you should always continuously reevaluate their heart rate, respirations, as well as oxygenation as determined by SpO2 monitoring. Make sure that you look over this table, because this will help you in treating your patients. Within 30 seconds of delivery, this is when you'll be drying, positioning the airway, whether or not we have to open it or not, or suction it out. And as you can see in this chart, where's our ALS stuff? It's at the bottom. We use an inverted triangle. This is because that relative frequency of need for resuscitative measures is often because the most simple care for newborns required is at the top. We start from the top, work our way down. Our more important stuff is up here. And guess what, folks? Y'all can do this. Hardly ever should we ever have to get down here. If we get down here, this was probably a preterm, wasn't getting any prenatal care, the mother wasn't taking care of herself. That's usually when we get to this point. Make sure that you keep their airway clear. Provide BVM at a rate of 1 to 2 breaths per minute. Reassess every 30 seconds when providing positive pressure ventilation. Make sure that the airway is clear by suctioning them out. You just want to ventilate just enough force to raise the infant's chest. Make sure that you don't rear back too far to prevent occlusion of the trachea, and make sure that you place some padding behind the shoulders to help keep the everything in line. If the heart rate continues to drop, you want to continue ventilations as well as begin providing chest compressions per AHA guidelines. It's a two-person technique. Remember, we do the encircling thumb technique. If there's any meconium present at birth and the child is crying vigorously with good respiratory effort and good muscle tone, do not do anything. Just monitor the patient. If the newborn has absent or depressed respirations with meconium present, suction the nose and mouth and immediately begin positive pressure ventilation. If they are term babies, you want to use room air And if the baby is preterm, use 21% or to 30% to titrate the appropriate extrauterine SpO2 level. Do not exceed 65% on a preterm neonate. If at any time the heart rate decreases to 60 beats per minute, immediately begin chest compressions and increase oxygen delivery to 100% via BVM. The reason we don't want to provide high flow oxygen to these children, definitely right at birth, is because of the chance of causing damage to the optic nerve and possibly causing them to become blind. Alright guys, that concludes this chapter. If y'all have any questions, make sure to let me know. Make sure that you're working on your Brady labs. Otherwise, I will see y'all next time in class. Y'all have a good one.